Hello, I'm Dr. Sam Goldhaber. I'm the interim chief of the Division of Cardiovascular Medicine at Brigham and Women's Hospital. I am also section head of vascular medicine and professor of medicine at Harvard Medical School. Today, I'm going to discuss venous thromboembolic disease. Here are my disclosures. And the learning objectives are to talk with you about optimal duration and intensity of anticoagulation after provoked or unprovoked pulmonary embolism or deep vein thrombosis, to discuss advanced therapy for acute pulmonary embolism beyond anticoagulation, and to focus on the use of low-dose tissue plasminogen activator, and to discuss prevention of venous thromboembolism in hospitalized medically ill patients after they are discharged from the hospital using a new DOAC called betrixaban. I'm going to begin with a case. This is a 44-year-old obese man who suffered a flare of ulcerative colitis requiring hospitalization. He suffered acute submassive pulmonary embolism during the hospitalization and was treated with rivaroxaban for 6 months. He had a negative hypercoagulability workup. At his 6-month visit in the office, he asks his doctor, "May I discontinue anticoagulation? Or at least, can you switch me to baby aspirin?" Now, before answering his question, let's review the Einstein Choice Trial, which enrolled more than 3,300 patients with provoked and unprovoked venous thromboembolism on a protocol where they had all been treated with conventional anticoagulation for 6 to 12 months prior to enrollment in this protocol that studied extended duration anticoagulation. And once entered into the protocol, patients were randomized to receive rivaroxaban 20 milligrams daily, or rivaroxaban 10 milligrams daily, or aspirin 100 milligrams daily. They were treated with one of these 3 regimens for 12 months, and then they were observed for an additional month off medical therapy for extended duration anticoagulation. And what was found was that among those patients enrolled with provoked venous thromboembolism, which constituted 60% of the entire group, or those with unprovoked venous thromboembolism, 40% of the enrolled cohort, in both cases, rivaroxaban compared with low-dose aspirin had a lower rate of recurrent events. When we dig down into the data, we see that rivaroxaban 20 milligrams versus 10 milligrams for extended duration anticoagulation had a much lower rate of recurrent VTE compared with low-dose aspirin. And with respect to safety and major bleeding complications, there was no statistically significant difference in major bleeding complications among the 3 groups: rivaroxaban 20 milligrams, rivaroxaban 10 milligrams, or aspirin 100 milligrams daily. It turns out that provoked minor persisting risk factors do predispose to recurrence. and these include inflammatory bowel disease, lower limb paresis or paralysis, congestive heart failure, obesity, family history of VTE, or hereditary thrombophilia, and provoked minor transient risk factors also predisposed to recurrence. These include immobilization, travel more than 8 hours, estrogen or pregnancy, or leg injury with impaired mobility. When we combine the 2 doses of rivaroxaban and compare them either with placebo or with low-dose aspirin by combining the Einstein choice trial that used low-dose aspirin with the Einstein extension trial that used placebo, we see among those patients with unprovoked VTE a marked drop in recurrence rate with rivaroxaban compared with placebo or aspirin. And this difference was even more apparent in cancer patients with VTE, where there were no recurrences with rivaroxaban. For patients with minor persisting risk factors or with minor transient risk factors for VTE, again, rivaroxaban in either of the 2 doses was far more effective than low-dose aspirin or placebo in reducing the recurrent rate of VTE. The one area where rivaroxaban did not have a role was in patients who underwent major surgery and had a provoked VTE in the setting of major surgery. There, it did not appear that anticoagulation really added anything to either placebo or low-dose aspirin, where the recurrence rate with VTE in the setting of major surgery was 0. Now, there are observational studies that are more than a decade old looking at the high VTE recurrence rate after anticoagulation is discontinued. And in this famous study from Padua, Italy, more than 1,600 DVT patients were enrolled, and those patients with idiopathic or unprovoked VTE had a 50% recurrence rate when followed for 10 years after stopping anticoagulation. And those patients who had a provoked VTE had a 20% recurrence rate 10 years out after stopping anticoagulation. The most recent CHEST guidelines state that if there is an unprovoked VTE with low to moderate bleeding risk, we suggest extended anticoagulant therapy with no scheduled stop date, over and in preference to 3 months of therapy. And I think the data from the Einstein extension study and the data from the Einstein choice study support this recommendation. But the next part about provoked VTE is outdated, and the guidelines have not kept up with the literature. Here it says, for a guideline that there is a provoked VTE by surgery or a non-surgical transient risk factor, anticoagulate for 3 months. We agree with the provocation by surgery, but we now have data from Einstein choice and Einstein extension saying that for a non-surgical transient risk factor, we should consider anticoagulation for greater than 3 months because there's a relatively high rate of recurrence outside of the setting of major surgery. Now, why might there be a role for aspirin to prevent recurrence? Well, it turns out that a pulmonary embolism is filled with white blood cells and with platelets in addition to red blood cells. Here we see a micrograph of a patient who had fatal pulmonary embolism, and in the trichrome stain, it's red. And we expect red because we're thinking about these red blood cells that are clumped together. But when we do more special staining of this pulmonary embolism, we find that the brown colored stain stains for polymorphonuclear leukocytes, polys, that go to areas of inflammation. And the blue stain shows us activated platelets that are filled with inflammatory mediators. So we see that a pulmonary embolism, or a DVT, really has red blood cells, polys, the white blood cells, and platelets. It's inflamed tissue. And we know that thrombin-induced inflammation can convert a resting platelet into an activated degranulating platelet. This releases pro-inflammatory mediators that can cause more thrombosis in a vicious circle. And one way we can reduce the conversion of resting platelets to activated degranulating platelets is to use low-dose aspirin. In this trial of extended duration therapy after 6 months of standard anticoagulation, we see in this pooled analysis of 2 trials where patients with VTE had originally undergone standard anticoagulation with 6 months of anticoagulation. They were then randomized to low-dose aspirin or to placebo, and the low-dose aspirin group had about a 35% reduction in recurrent events compared to the placebo group. Now, we used to think that we could, at the end of the first 3 to 6 months of anticoagulation, send off a D-dimer level, and the D-dimer result would tell us whether a patient required continued anticoagulation or whether anticoagulation could be safely discontinued. It turns out that the D-dimer disappoints. In this Canadian study of patients with unprovoked VTE, they were managed with 5 months of warfarin, and then a D-dimer was sent, and it turned out that those patients with a negative D-dimer had high rates of recurrence, 8% in the first year for men and 5% in the first year for women. And for those with positive or elevated D-dimer levels, the recurrence rates were double. The NOACs are very effective for the extended treatment of VTE, and the NOACs will reduce the recurrence rate compared to placebo 80 to 90%. What are some core explanations for a high VTE recurrence rate? There can be persistent VTE risk factors, such as obesity, diabetes, metabolic syndrome, or sedentary lifestyle. There can be persistent inflammation that may wax and wane in intensity. Or there can be persistent hypercoagulability that is either genetic or acquired. Here are some take-home lessons from Einstein choice. VTE, we now believe, for the most part, is a chronic inflammatory disease with a high recurrence rate after discontinuing anticoagulation. For extended duration anticoagulation, rivaroxaban is 70% more effective and as safe as aspirin to prevent recurrent provoked or unprovoked VTE. Now I'd like to switch topics and talk about the advanced management of pulmonary embolism in situations when anticoagulation alone might not suffice. I'll begin with the case of a 62-year-old woman with a blood pressure of 102/60 and a heart rate of 134 and respiratory rate of 30, oxygen saturation of 89%, who had a saddle pulmonary embolism on her chest CT scan with a large clot burden. Should she receive thrombolysis or heparin alone? Here we see on the chest CT scan that her right ventricle is 2 to 3 times wider in diameter than her left ventricle. This is a poor prognostic sign and shows right ventricular failure. Our therapeutic options include continuing intravenous heparin as monotherapy, switching from intravenous heparin to enoxaparin as monotherapy, giving TPA 100 milligrams over 2 hours through a peripheral vein, giving TPA 50 milligrams over 2 hours through a peripheral vein, or taking the patient to the cath lab or interventional radiology lab to administer ultrasound-facilitated catheter-directed thrombolysis, such as 24 milligrams of TPA. Well, with standard treatment, what happens to the pulmonary embolism death rate among patients successfully discharged home? By 30 days, 8% of the patients overall die. Most of them die of recurrent pulmonary embolism, and 20% die within 6 months. There is a high pulmonary embolism mortality rate at 30 days, as shown here, and a high pulmonary embolism mortality rate at 6 months is shown here in the top part of this slide. Unfortunately, there's also a high 30-day readmission rate for pulmonary embolism patients. It's about 15%, making pulmonary embolism the second most common reason for rehospitalization within 30 days, with heart failure being the number one reason. Over the past 30 years, we have trended toward utilizing lower doses of TPA because they are associated with less major and less minor bleeding. The lower durations of infusion also lower the cost of therapy and lower the duration of the hospital stay. We have a lot of choices for thrombolysis. We can give full dose TPA, 100 milligrams over 2 hours, FDA approved in 1990. We can give half dose TPA, 50 milligrams. This is the so-called Moppet regimen. We can give catheter-directed ultrasound facilitated TPA, 24 milligrams. The FDA approved this approach in 2014. Or we can give the Optilyse pulmonary embolism dose, TPA, for example, in a dose as low as 8 milligrams over 2 hours. This is less than 1/10 the original dose of 100 milligrams over 2 hours. Now, meta-analysis shows us that thrombolysis in patients with submassive pulmonary embolism is actually life-saving, with a reduction in mortality of about 50%. On the other hand, the all-cause mortality, although that remains lower in the patients receiving thrombolysis compared to those receiving anticoagulation alone, the major bleeding complication rate is more than 3 times higher in the TPA patients compared with those receiving heparin alone. Another approach is the so-called Moffitt regimen of 50 milligrams of TPA compared with intravenous heparin. The 50 milligram dose, 10 milligrams is given over 1 minute as a bolus, followed by 40 milligrams administered intravenously over 2 hours. In the pivotal trial in 2013, no bleeding complications and no intracranial hemorrhage were reported. Also, the pulmonary artery estimated pressures were lower in the TPA group compared with the controls. Ultrasound facilitation of catheter-directed thrombolysis causes the fibrin strands to thin and causes the network to loosen. This is one of my patients receiving the standard 24 milligram dose of TPA over 12 hours, 12 milligrams per catheter. You can see these black things are actually ultrasounds that are buzzing the clot while the TPA is being administered to bust or break up the clot. We believe that ultrasounded facilitated catheter-directed thrombolysis will improve blood flow in the distal pulmonary arteries or microvasculature, as shown here. We can summarize catheter-directed thrombolysis versus heparin as follows. For submassive pulmonary embolism, catheter-directed thrombolysis will lyse the clot, heparin will not. Catheter-directed thrombolysis will rapidly reverse pulmonary hypertension, heparin will not. Catheter-directed thrombolysis will rapidly reduce right ventricular size, heparin will not. And finally, catheter-directed thrombolysis will help to clean out the microvasculature, and heparin will not. Here we see an example of a massive pulmonary embolism extracted from a pregnant patient. Here we see that in the inferior vena cava, these filling defects are actually large clots that were caught by the inferior vena caval filter, thus preventing massive pulmonary embolism from ensuing. When we look at all the studies of inferior vena caval filters compared with controls, we see that the filters help prevent subsequent pulmonary embolism at the cost of causing more subsequent DVT. There is no significant difference from a statistical viewpoint in pulmonary embolism-related mortality with IVC filters. And subsequent bleeding and all-cause mortality are no different in the filter group compared with the no-filter group. My last topic centers on the theme, an ounce of prevention is worth a pound of cure. Despite in-hospital VTE prophylaxis with unfractionated heparin or low molecular weight heparin, there are more than 400,000 VTE events occurring annually in this patient population. About half occur within 6 weeks of hospital discharge. Prior to betrixaban, no agents were FDA approved for extended duration anticoagulation. Now, I was never convinced that readmission with new VTE is a problem at my hospital. However, this survey shows my hospital in the blue bars with a substantially higher rate of readmission for VTE compared with hospitals throughout the Commonwealth of Massachusetts or hospitals throughout the United States. Now, I believe this is probably due to our having higher risk patients at the Brigham. Betrixaban is the new DOAC. It is a factor Xa inhibitor. It has a long 19 to 25 hour half-life, a low peak to trough ratio, 17%, perhaps only 7% renal clearance, and there is an antidote called andexanet. Betrixaban was FDA approved based on this pivotal trial called APEX. The APEX looked at standard duration enoxaparin prophylaxis for 10 days versus betrixaban, which had a loading dose of 160 milligrams and was then given 80 milligrams once daily. We see at the end of this trial, all patients underwent ultrasound. Then they were followed for a month after the drug portion of the study ended to determine whether VTE had ensued. In the APEX trial, the predominant admitting diagnosis was heart failure, present in about 45% of the more than 7,000 patients who participated in the trial. Here I summarize the results of betrixaban given for 35 to 42 days compared with enoxaparin. Betrixaban demonstrated a 24% reduction in VTE, a 46% reduction in symptomatic VTE, a 30% reduction in fatal or irreversible events, a 56% reduction in VTE-related rehospitalization, and a 56% reduction in stroke. There was no increase in major or fatal bleeding with betrixaban. And here are take-home points. First, for extended duration therapy, rivaroxaban is 70% more effective and as safe as aspirin to prevent recurrent provoked or unprovoked VTE. Next, critically ill PE patients warrant thrombolysis or embolectomy. And finally, betrixaban is a new DOAC, FDA approved to prevent VTE during and after rehospitalization. All right, I have some single best answer questions for you. What parameters are used to determine advanced PE therapy? Clinical assessment, right ventricular size, right ventricular function, troponin elevation, or all of the above? You should vote. The correct answer is all of the above. And after completing 6 months of full dose anticoagulation for acute VTE, we can say aspirin is no more effective than placebo, or aspirin has significantly fewer major bleeding complications than NOACs, or aspirin is as effective as a NOAC, or aspirin is more effective than placebo, or that aspirin does not cause major bleeding. And the single best answer is aspirin is more effective than placebo. And finally, here are some references that I hope you will enjoy.